In this session, we are going to talk about complications of uveitis, which we have been mentioning in the previous sessions, but with a little more detail in this session. Starting with cataract, cataract occurs in uveitis because of the inflammation, and when the inflammation is chronic or recurrent, chances of cataract developing is more. And apart from inflammation, prolonged therapy of uveitis with steroids, whether topical, local or systemic, can induce cataract formation. Indications for cataract surgery include situations where the cataract appears to be visually significant and there appears to be potential for visual gain after cataract surgery. In juvenile idiopathic arthritis associated uveitis in children, cataract surgery may be required to prevent development of amblyopia, and a compromised view of posterior segment in a patient with posterior uveitis, panuveitis or posterior segment complications of uveitis may require cataract surgery for adequate monitoring and treatment of the posterior segment involvement. Preoperatively, maximum control of inflammation for at least 3 months is required, and this is a very important dictum to remember. A quiet eye without anti-inflammatory therapy for 3 months is ideal. A few cells are acceptable, but flare is not acceptable. But certain chronic uveitis entities like VKH, sympathetic ophthalmia and Behçet's disease have to be maintained under prolonged anti-inflammatory therapy including IMTs, and this IMT therapy cannot be withdrawn before cataract surgery to check whether the inflammation is controlled without treatment prior to cataract surgery. There are certain exceptions to this dictum, such as lens-induced uveitis, which needs to be operated as soon as the inflammation is controlled, in patients with cataract preventing necessary posterior segment monitoring and treatment, and Fuchs uveitis syndrome, which actually does not respond to anti-inflammatory therapy. Preoperative prophylaxis prior to cataract surgery to prevent postoperative recurrence of uveitis should be instituted 3 days prior to surgery, and includes initiation or increase of dosage of topical and systemic corticosteroids. Topical steroids should be intensive as frequently as 1 hour, and systemic steroids should be given at the dosage of 1 mg per kilogram per day. Infectious uveitis entities such as herpes or toxoplasma should be given prophylactic appropriate antimicrobials without systemic steroids prior to cataract surgery, and either of these 2 regimens is continued during and immediately after surgery. If a patient is on preoperative immunomodulatory therapy, the regimen is continued peroperatively and postoperatively, and this occurs in situations of chronic uveitis such as Vogt-Koyanagi-Harders syndrome. Peroperatively, phacoemulsification is the method of choice of cataract extraction with posterior chamber in the bag hydrophobic acrylic IOL implantation being well tolerated in patients with uveitis. Achieving in the bag IOL implantation in uveitis patients is very important because it prevents the IOL material to come in contact with the uveal tissues. A hydrophobic acrylic material is preferred because compared to the other materials, the hydrophobic acrylic material has been shown to accumulate the minimum amount of inflammatory deposits on the lens. So sulcus implantation of the IOL should be avoided so that the IOL does not come in contact with the uveal tissues. During surgery, meticulous removal of cortical material is indicated because cortical material or any lens material is pro-inflammatory. At the end of surgery, periocular or intravitreal corticosteroids helps in control of the postoperative inflammation. Now, ocular comorbidities which we may have to tackle in patients with uveitis include corneal opacity, which may compromise with visualization of the anterior segment, scleral thinning, which may need clear corneal incision, a shallow anterior chamber because of iris bombay formation, pupillary abnormalities such as posterior synechia, meiosis or pupillary membranes, which may require maneuvers such as synechiolysis, pupillary membrane removal, and pupil expansion devices such as iris hooks. A calcified anterior capsule is also common in uveitis patients, in which situation a capsulorhexis may not be possible and can-opener capsulotomy may need to be done. Zonular weakness, though rare, can occur in patients with uveitis and may need lensectomy or vitrectomy, and coexisting posterior segment pathologies such as dense vitreous opacities, epiretinal membranes, and tractional retinal detachments may require vitreoretinal intervention. There are certain relative contraindications of IOL implantation such as iris neovascularisation, history of excessive membrane formation and recurrent posterior synechia formation, and hypotony. JIA-associated cataracts in children are a special situation, and many experts prefer to leave very young JIA patients aphakic, and that makes amblyopia prevention a special concern. If IOL is planned, IOL power adjustment is required in children, and pediatric cataract surgery requires posterior capsular excess with anterior vitrectomy to prevent posterior capsular opacification, and this is all the more required in patients with uveitis. Following cataract surgery in an uveitis patient, close monitoring is required to detect postoperative flare-up of uveitis, and a gradual tapering of topical or systemic steroids is recommended. Rapidity of the taper depends on chronicity of the uveitis before surgery and intensity of postoperative inflammation. So, a chronic uveitis or severe postoperative inflammation requires very slow taper of topical and systemic steroids. Role of NSAIDs to control uveitic inflammation is uncertain. Following cataract surgery in uveitis patients, complications which are more prone to occur include postoperative flare-up of the inflammation, macular edema, higher incidence of posterior capsular opacification, and YAG capsulotomy to treat PCO may itself cause flare-up of the uveitis, and YAG capsulotomy may be required multiple times in patients with uveitis. IOL deposits and inflammatory cocooning of the IOL back complex may occur in uveitis patients, particularly those with intermediate uveitis, with the inflammation being located near the region of the lens, and severe IOL deposits may need explantation of the IOL. Glaucoma due to uveitis can be secondary open-angle glaucoma or secondary angle closure glaucoma, and each can be acute or chronic. Acute secondary open-angle glaucoma can be due to trabeculitis, clogging of trabecular meshwork with inflammatory debris, or because of corticosteroid therapy. Trabeculitis is said to occur with herpetic and toxoplasma uveitis and in glaucomatocyclitic crisis, and treatment of acute secondary open-angle glaucoma due to trabeculitis is control of inflammation and intraocular pressure in addition to antimicrobial therapy if an etiologic agent can be detected. Rise in intraocular pressure can occur following topical, local and systemic therapy with steroids, and usually starts 2 to 3 weeks after initiation of treatment with steroids, and it has been seen that difluprednate drops and fluocinolone intravitreal implants cause more IOP elevation than their respective alternatives. Chronic secondary open-angle glaucoma occurs due to fibrosis of trabecular meshwork following trabeculitis and usually needs glaucoma surgery. Secondary acute angle closure glaucoma can occur due to either iris bombae or due to forward rotation of the iris ciliary body complex. Iris bombae occurs following posterior synechia progressing to seclusio or occlusio pupillae, and in iris bombae, typically peripheral anterior chamber appears flatter than the central anterior chamber. So iris bombae occurs when 360 degrees of the pupillary margin is stuck on the anterior lens surface, and aqueous humor produced in the posterior chamber cannot escape into the anterior chamber through the pupillary aperture. As a result, there is a pressure buildup in the posterior chamber and mid-peripheral iris bulges. So what we get is a shallowing of the periphery of the anterior chamber, while the central part of the anterior chamber remains relatively deep. Treatment of iris bombae is either with YAG iridotomy or surgical iridectomy, and the iris openings in either situation must be multiple and large, and this has to be combined with appropriate control of inflammation and intraocular pressure. Laser iridotomies in patients with uveitis has a tendency to close and may need to be repeated later on. And following chronic iris bombae, if 360 degrees peripheral anterior synechia form, then iridotomy or iridectomy becomes ineffective in controlling the intraocular pressure. Forward rotation of the ciliary body is another cause of secondary acute angle closure glaucoma in uveitis, and it usually occurs from anterior choroidal thickening, which typically occurs in VKH and sympathetic ophthalmia. And in this situation, in contrast to iris bombae, there is equal shallowing of central and peripheral anterior chamber. USG and UBM can show choroidal thickening and anterior rotation of the ciliary body, and treatment of forward rotation of the ciliary body is with cycloplegia, because cycloplegia can push the ciliary body posteriorly. And in addition to cycloplegia, a control of inflammation and intraocular pressure must be instituted. In this mechanism of secondary acute angle closure glaucoma, iridotomy does not help. Chronic angle closure glaucoma in uveitis occurs when there is peripheral anterior synechia formation, which will require glaucoma surgery with or without goniosynechiolysis. Treatment of uveitic glaucoma involves control of the inflammation and control of intraocular pressure. So simultaneous control of inflammation is paramount, and it is essential for preventing both further uveitic complications and also failure of glaucoma surgery. And treatment of the raised intraocular pressure can be medical or surgical. Aqueous suppressants can be used to treat raised intraocular pressure in uveitic glaucoma, and in uveitic glaucoma, prostaglandin analogues, though known to be pro-inflammatory, are not contraindicated if combined with appropriate anti-inflammatory therapy. However, prostaglandin analogues may worsen herpetic uveitis and uveitic macular edema, so these are relative contraindications to therapy with prostaglandin analogues. Pilocarpine is contraindicated in treatment of uveitic glaucoma because it promotes blood ocular barrier leakage and also induces miosis, promoting posterior synechia. When surgical therapy for uveitic glaucoma becomes necessary, when medical treatment of glaucoma fails, preoperative uveitis control and prophylaxis against recurrence of uveitis following surgery is indicated, just as prior to cataract surgery. But whereas in uveitic cataract surgery, preoperative control of inflammation is recommended for 3 months, uveitic glaucoma surgery may need to be done earlier after control of inflammation to normalize the intraocular pressure as quickly as possible and prevent further optic nerve damage. Trabeculectomy alone without antimetabolites usually fail in uveitis, and trabeculectomy with antimetabolites is one modality of surgical therapy for uveitic glaucoma. Compared to trabeculectomy with antimetabolites, aqueous drainage devices are more effective in lowering intraocular pressure with less chance of long-term failure in patients with uveitic glaucoma. And aqueous drainage devices are particularly indicated in pseudophakic and aphakic eyes. Cyclodestructive procedures are contraindicated because they promote inflammation and increase the risk of hypotony. In uveitic glaucoma, laser trabeculoplasty is considered ineffective, and role of MIGS in uveitic glaucoma is uncertain. Hypotony is another complication of uveitis, and the signs of hypotony are hypotonic maculopathy, choroidal detachment, optic disc edema, and corneal edema. So we find retinal folds here and optic disc edema following hypotony. Acutely, hypotony can occur in uveitis due to ciliary body inflammation, and this is transient and disappears with anti-inflammatory therapy. Long-term hypotony can occur due to ciliary body detachment with atrophic ciliary processes, and treatment of chronic hypotony includes long-term anti-inflammatory therapy, removal of the cyclitic membranes if the ciliary processes appear intact, and this should not be delayed because delay in removal of cyclitic membranes over the ciliary body reduces chance of increasing the intraocular pressure. If ciliary processes appear destroyed, intravitreal viscoelastics or silicone oil can be injected to maintain the shape of the eye. Macular edema in uveitis usually occurs from inflammatory mediators in the vitreous cavity, but infrequently it may arise from vitreomacular traction. And clinically, severity of the macular edema may not correlate with severity of the inflammation. Macular edema may persist despite adequate and appropriate control of inflammation. Treatment of uveitic macular edema includes control of the inflammation with systemic steroids and immunomodulatory therapy as necessary. In addition, periocular triamcinolone or intravitreal steroids can be administered. And options for intravitreal steroid administration includes triamcinolone and implants such as dexamethasone and fluocinolone. Compared to periocular triamcinolone, intravitreal steroids are more effective in controlling macular edema but with a higher risk of raised intraocular pressure, and in vitrectomized eyes, the duration of action of intravitreal steroids is reduced. Intravitreal anti-VEGF is also an option for treating macular edema And if there is a poor response with steroids and anti-VEGF, and OCT shows an associated vitreomacular traction along with the macular edema, removal of the vitreomacular traction can help. Other treatment options for macular edema include oral acetazolamide, which can be effective in eyes with persistent macular edema despite control of the inflammation. Intravitreal methotrexate has also been shown to be effective in uveitic macular edema, and efficacy of topical NSAIDs in uveitic macular edema is uncertain. Band keratopathy occurs due to calcium deposition at the level of Bowman's membrane. It starts at the limbus and gradually progresses towards the center, and typically it has these clear spaces within the area of band keratopathy. It causes irritation and gradual loss of vision, and typically occurs in chronic uveitis, and is particularly known to occur in children with JIA associated uveitis. Band keratopathy can be removed by epithelial debridement followed by EDTA chelation. Retinal neovascularization can occur in uveitis from ischemic retinal vasculitis as well as chronic inflammation, and retinal neovascularization may disappear with control of inflammation alone, else it requires laser photocoagulation and/or anti-VEGF along with adequate inflammation control. Choroidal neovascularization can occur with choroidal inflammation, following which there may be breaks in the black membrane. Treatment of choroidal neovascularization includes anti-VEGF, and simultaneous therapy with systemic steroid and immunomodulatory therapy is essential in choroidal neovascularization following uveitis for adequate efficacy of the anti-VEGF therapy and reduction of risk of recurrence of CNV. So this is a very important principle to remember, that choroidal neovascularization secondary to uveitis should be treated with anti-inflammatory therapy as well as standard anti-VEGF therapy for choroidal neovascularization itself. Other posterior segment complications of uveitis include chorioretinal scarring and atrophy following choroiditis and or retinitis, epiretinal membrane and macular hole which occurs with vitritis, and it has been shown that epiretinal membrane and macular hole in uveitis patients may respond to anti-inflammatory treatment alone. Retinal detachment can occur in uveitis and can be rhegmatogenous, tractional or combined, and this occurs with necrotizing retinitis and vitritis, and in this situation there is a higher risk of proliferative retinopathy followed by recurrent retinal detachments. Vitreous opacities by themselves can compromise vision. Thank you for listening.